Hi, everybody. Thank you for joining. We're going to wait another about a minute just to let people log in. Okay, I'm going to go ahead and get started with the introduction. Thank you for joining us for our UIC Global Health Colloquium. The Colloquium is a monthly lecture series co-sponsored by the Health Science Colleges. It takes place on the first Wednesday of every month. This week is actually National Public Health Week as well. They have a daily theme for National Public Health Week, and today's theme is climate change. So it's very appropriate to have our speaker that we have today with us. My name is Allison Lofthouse. I'm the Assistant Dean for Global Health at the UIC School of Public Health. We're very excited to have with us Dr. Marina Romanello here. Dr. Romanello is the Executive Director of the Lancet Countdown, tracking progress on health and climate change, an independent and multidisciplinary research collaboration of almost 300 researchers around the world and headquartered at University College London's Institute for Global Health. The Lancet Countdown tracks and drives progress towards the world, which is responding to climate change in a way that protects and promotes public health. Dr. Romanello led a team of researchers in developing England's National Health Service's net zero commitments and is a member of numerous advisory boards for projects focusing on health and climate change. She trained as a clinical biochemist at the University of Buenos Aires in Argentina, and she holds a PhD in biomedical sciences from the University of Cambridge in the UK. Her research background spans from toxicology through to environmental health and climate change, and she has previously carried out her research in the Technological Institute of Buenos Aires, the University of Cambridge, and the Francis Crick Institute in England. So we are very excited to have her. Thank you, Dr. Romanello, for sharing your time with us today. And with that, I'll let you go ahead and get started.
Excellent. Thank you so much to everyone, and particularly for this invitation. It's we were just discussing with Alison how encouraging it is to see that there's much more attention being put to climate change and health. So I commend you also for organizing this event. I'm going to try and share my screen. I hope you will see the full screen slides. Let me know if this doesn't show up. I think you're seeing it now. So what I'm going to do today, as you've heard, I'm the Executive Director for the Lancet Countdown on Health and Climate Change. So I'm going to tell you a bit about what we do at the Lancet Countdown, why we do it, and I'm going to share with you some of the key findings of our latest report and end up with a few notes on why it's so important that healthcare professionals, health systems globally are paying much more attention to climate change as we move forward. So before we go there, just to set the scene a bit, the Lancet Countdown is an international global collaboration, as you just heard. And each year we produce these indicator reports that get published in the Lancet. They are published always ahead of the climate change negotiations of the UN Framework Convention on Climate Change, known as the COP meetings, that happen generally in November or December each year. And with these reports, we publish over 50 indicators that track the different aspects of health and climate change with the purpose of providing sound, robust, state-of-the-art evidence on what's happening globally with health and climate change, in the hopes that that can inform the negotiators in ensuring that health is mainstream promoted through their international negotiations each year. Our latest report, we published it last November, and it's the product of 114 researchers that collectively contributed to it. As you can see, we have universities from all around the world, leading universities and UN institutions that partner in this project. And the approach that we take with Lancet Countdown is understanding health in a holistic view. So we understand that health is not only disease, but it's also, as you will probably agree, the environmental, the social, the economic conditions that determine health and well-being. So with that in mind, we divide our work into 5 working groups. What you're seeing on screen is now the diagram of those 5 working groups. And in particular, the thing that you see in the middle, the health impacts of climate change, is the first working group that we have. It monitors the evolving health hazards of climate change, the exposure to those hazards, and the associated risks and eventually impacts of climate change on health. Our second working group is on health adaptation. It looks at the extent to which we're adapting our health systems, but also the health supporting systems to cope with the changing climate and to continue to enable good health and good well-being in the face of climate change. The third working group looks at the health benefits of mitigation. This is a working group that has a lot of indicators that look at our energy system, our food system, and all of the human systems that contribute to greenhouse gas emissions, but particularly focus on the extent to which actions to tackle climate change can offer substantial health co-benefits, the extent to which we are delivering those co-benefits, and what are the opportunities for health through climate action. The fourth working group looks at the economic impacts and transition, the extent to which we're adapting our financial systems to climate change, and the extent to which that financial and economic transition is enabling a healthier future, as well as the economic impacts and losses from climate change. And last but not least, our fifth working group looks at the political and public context on health and climate change. What we're looking at there is the extent to which key actors in society, policymakers, the general public, scientists, companies, are understanding that when we talk about climate change, we're talking about the most fundamental health crisis that we have ever faced. The way that we select our indicators and this framework came from a big consultation involving scientists, professionals, and policymakers in 2016. And we have a framework whereby the indicators are selecting according to how they fit within that framework, following the criteria that you see on screen. The indicators that we produce need to be meaningful, tracking a meaningful aspect and well-established aspect of the relationship between climate change and health. It needs to be relevant to policymakers and to the scientific community. They need to be scientifically sound, reproducible, temporally representative. They have to cover enough time span to allow for the changes driven by climate change to be observed and the policies in response also to be captured. They must also be geographically representative. What I'm going to share with you is the product of the global Lancet Countdown report. So we're looking at global coverage. And obviously, we want to be able to update the indicators year on year to offer a sort of a stock take of what is the latest state of climate change and health, and to be able to guide actions as we move forward efficiently and reactively. As I said, I'm going to share with you the findings of the global Lancet Countdown, but in addition to our global effort, we now have 6 regional centers around the world that look more in depth at what's happening in critical world regions. As you can see, we have one in Europe, we have South America, Oceania, Asia, soon in Africa, small island developing states, and we're hoping to open one in North America shortly soon. So looking at our latest report, and when we think about climate change, the first thing that comes to mind is increased temperatures, is increased heat exposure. And you will know that heat exposure is not only very uncomfortable, but it's also potentially lethal, particularly to very vulnerable populations. These are elderly populations, people over 65 years of age, that don't thermoregulate well, that are at acute risk from extreme heat events. It also involves those with underlying predisposing health conditions like heart disease, lung disease, kidney disease. But it also affects very young children, pregnant mothers and their unborn child, and those in vulnerable situations and the urban poor. What we're monitoring here is heat-related mortality as it's evolved since the 90s, precisely in one of these very vulnerable populations, in people over 65 years of age. And through a global exposure response function, we model heat-related mortality. And what we estimate is that it has increased by 85% since the 90s. And that this is more than twice the level of increase that we would have expected under constant temperatures. We're seeing heat-related mortality all over the world, increasing in numbers. And this is just the tip of the iceberg. We know that for every heat-related death, we will have an enormous burden of disease, a huge increase in morbidity associated with extreme heat too. And generally, we think that the most vulnerable parts of the world, rightly so, are low middle income countries. But what is interesting is that because of the aging population and because of the high incidence of underlying chronic health conditions, Europe has the highest total rate of heat-related deaths in recent years. Aside from the health impacts, the direct health impacts of increased heat, what we're seeing is also that the increased temperatures and increased exposure to heat is undermining our health in indirect ways. What I'm showing you here on screen is the loss of labor capacity that results from heat exposure. There's physiological limits to how much physical work we can do under high temperatures. And when temperatures go up, workers need to take more breaks, need to hydrate, need to protect themselves from the heat. So extreme heat exposure is limiting the effective hours of labor globally. And we estimate that since the 90s, it led to a loss of 42% of more potential labor hours in 2022, and that is associated with a loss in global income of $863 billion US. This is important not only because it undermines the economy, but also because it undermines the livelihoods of families, particularly in the most vulnerable world regions. As you can see in the graph on the right, when we divide countries according to their Human Development Index, you can see that it is the low Human Development Index countries that see the highest losses as a proportion of their GDP, and that the most affected sector of labor is the agricultural sector, a sector in which workers have limited opportunities to shield from the heat, and generally a sector that delivers local food resources, particularly in low middle income countries. And therefore, this will have cascading impacts on local food availability, local food security, as I said, livelihoods, income, and the socioeconomic conditions on which health depends. And beyond the impacts on the agricultural sector from extreme heat exposure, we're also seeing that climate change is increasingly affecting food security. By looking at the Food Insecurity Index developed by the Food and Agricultural Organization, we're monitoring here the extent to which self-reported food insecurity is changing and how it relates to the increased incidence of heat waves and drought events. And what we find is that in a baseline that is centered around the 1990s, in recent years, we've seen 127 million more people experiencing food insecurity as a result of the increased incidence of heat waves and of drought events. And this is just in 69 countries that we've analyzed. And these are just some of the impacts of climate change. Climate change is also affecting precipitation patterns, humidity, temperature, and that also affects the incidence and the distribution of infectious diseases, particularly vector-borne, foodborne, waterborne, or airborne infectious diseases. Climate change is also affecting air pollution. It's increasing the exposure to dust. It's also increasing the exposure to aeroallergens like pollen. It is affecting respiratory health. It's affecting nutrition, as we just discussed. And all of these impacts are happening in parallel. They're compounding one another, and they're generating a bit of a perfect storm in which different populations will be hit by these multiple risks of climate change simultaneously. One thing that I haven't mentioned so far, because we have so little data for, is the impact on mental health of these threats of climate change, both directly. We know that exposure to extreme temperatures, exposure to extreme precipitation has impacts on mental health directly, as well as indirectly through the exposure to extreme weather events, to the resulting disasters, and to the physical deterioration and the physical impacts as well. One thing that is also very important to take into account is that the way in which climate change affects our health will be always determined and sieved through the social mediating factors, the extent to which we can access health services, the resilience and the robustness of the essential infrastructure that surrounds us, the extent to which we have a social fabric that can allow us to cope better with the impacts of climate change. So in the face of this perfect storm of climate change, it's critically important that we strengthen these social mediating factors and that we do as much as we can in terms of adaptation to the threats of climate change. There's a lot of things that we can do to adapt to climate change, and this would reduce the risk that we're facing, that will reduce the impacts of climate change. But we're still falling very far behind from the goals of adaptation. What I'm showing you here on screen is just one example of the many different dimensions of adaptation, and it involves the extent to which countries are implementing climate-informed health early warning systems for different critical threats from climate change to health. Early warning systems, of course, are a first step. Then we need to have early response systems, adaptation plans, and implement robust systems to effectively respond to climate change. But what I wanted to show you here is that once again, when we divide countries according to their Human Development Index, no matter which is the climate threat that we're looking at, we always see this perfect ladder in which is always the low Human Development Index countries that are lagging in the adoption and implementation of these potentially life-saving early warning systems, and that we see this perfect ladder of inequities. When we try to delve a bit more deeper into why we're seeing countries falling behind in implementing essential life-saving adaptation strategies, what we hear the most is that this is due to a lack of financial or human resources to support the implementation of these measures. I'm giving you here an example of the investments of the Green Climate Fund, and we see that only about 18% of the very meager $205 million that the Green Climate Fund allocated to adaptation projects in 2022 went to supporting projects with potential health benefits, where health benefits were identified as an end goal. So we're still keeping the most vulnerable countries most unprotected, and obviously they will be impacted harder, and this is contributing to amplifying the gap of global health inequities that come from climate change. Beyond that, we're taking spontaneous responses to the changing climate. As temperatures rise, we're seeing globally more and more people adopting active cooling strategies, the use in particular of air conditioning, technology that is very widespread in high-income countries, particularly in the US, in North America. And more households are now adopting also air conditioning as a way of shielding from the heat. We estimate that in 2019, air conditioning averted about 195 heat-related deaths in adults over 65 years of age. However, air conditioning is also contributing substantially to greenhouse gas emissions because they're very energy intensive and our energy grids are still very carbon intensive. They're also contributing to air pollution. As you can see, actually I don't have it here in the screen, but it's contributing to air pollution from the use of dirty source of fuel and of energy. And another thing that is very important is that air conditioning releases heat to the outside. It releases heat waste to the outside. So it's making urban centers really hot. It exacerbates the urban heat island effect, and it contributes to the inequities in urban centers between people that can afford to access air conditioning and those that can't. Most importantly, it adds extra pressure on our energy grids. I'm from Argentina. Last year, we had a ridiculously hot summer season and a heat wave in which the city of Buenos Aires remained without electricity as a result of the overuse of air conditioning during the peak of a heat wave. That meant that people did not only not have access to air conditioning, but also people living in buildings did not have access to water because the pumps were not working. People were stuck in very hot buildings with little access to urban green spaces and little opportunity to access sustainable cooling solutions. So the excessive use of air conditioning is what we call a maladaptive response. There's no doubt that in some settings, it will be necessary, it will be beneficial, particularly in places like where you have elderly care homes or where air conditioning and active cooling is crucially important, like hospital settings. But in most places, it's not necessary. And the good news is that we have better systems of offering cooling, particularly in urban centers. The implementation of urban green spaces is really effective in providing local cooling. It can also reduce the risk of flash floods. It can also deliver a cleaner air. It can help purify air. And it can also deliver mental and physical health benefits through increased exposure to urban green space that has been shown to decrease even all-cause mortality in urban settings. So it has an enormous health benefit for health. But the bad news is that we're not really making good use of this resource available to us. Only about 30% of the global urban centers were found to be moderately green or above through our report. And particularly in the UK, an area where we have good access to urban green spaces, I'm showing you here as an example, of the 10 cities with more than 500,000 inhabitants, only two had low levels of urban green space, 6 had moderate levels of urban greenness, and none of them had very high levels of urban greenness, a very green country per se. So even in high resource settings, we're lagging in the adoption of these technologies with an enormously high impact to our health and well-being. So we're facing increased risk from climate change. We're lagging behind in the adaptation response. And the worrying thing is that this could be only the start of a very dangerous future. For the first time last year, we did projections of what different climate scenarios could look like for health. And even if we manage to keep temperatures globally within 2 degrees of global mean heating, without a drastic increase in adaptation and mitigation efforts, we could see heat-related mortality in people over 65 increasing by 370%, 50% more labor hours lost due to heat exposure, over 500 million more people experiencing food insecurity as a result of increased incidence of heat waves, and infectious diseases spreading more and more around the world. So a 2-degree scenario is enormously dangerous. So we have to urgently increase our efforts to adapt to climate change, but it's very unlikely that we will be able to effectively adapt to this type of scenario. So increasing our mitigation efforts, reduction of greenhouse gas emissions to keep temperatures as close as possible to 1.5 degrees is crucial. And here's where we come to the determinants of health through greenhouse gas emissions. Each ton that we continue to emit of carbon dioxide worsens our health outlooks, makes adaptation efforts more difficult. And what is more important is that we know that through public health interventions that are centered around people's health and the reduction of greenhouse gas emissions, we can deliver enormous health co-benefits for human health. So looking at what's happening in terms of mitigation, the energy sector is the largest single contributor to global greenhouse gas emissions. And unfortunately, we're not doing much in terms of decarbonizing the energy sector, even though we do have the technology and the knowledge on how to do it. Globally, fossil fuels still contribute to about 80% of all global energy. And energy sector emissions reached a record high level in 2022. We have new data that shows that another record high has been reached in 2023. What is even more worrying is that although we're rapidly increasing the adoption of renewable energies, we're still very far behind the level needed to tackle climate change. Renewables make about 11% of all global electricity generation. But if you look at, in very high income countries, but if you look at the graph here on the right, you can see that low human development index countries are once again being left behind in the transition towards healthy low carbon energy systems, with only 2.3% of their electricity being generated from clean renewables. And the reason why this is important is not only that our energy systems keep on pumping greenhouse gases into the atmosphere, exacerbating climate change, but also because of the missed opportunity of increasing access to energy and improving our air quality. We estimate that about 2 million deaths were attributable in 2020 to exposure to outdoor air pollution coming from dirty fuel burning. This is outdoor air pollution at all, and only from dirty fuels. Looking at total exposure to air pollution, we estimate about 9 million deaths. But these 1.5 million deaths could be avoided by transitioning to healthy, clean energy. And when we look at what happens in terms of indoor air pollution, we're seeing that households around the world are still very highly reliant on dirty fuels. They're still burning biomass, that's one of the dirtiest sources of fuel, coal, and fossil fuels inside people's homes, contributing to really low quality of air and a very high level of exposure to toxic air pollutants. Once again, you can see if we divide the world according to Human Development Index, it is the low Human Development Index countries that are disproportionately dependent on the use of biomass to meet their energy needs. This is what energy poverty looks like. is what it looks like not to have access to clean energy, not to have access to electricity. And it's resulting in the 62 countries that we've analyzed, mostly falling in the low and medium human development index group, to 140 deaths per 100,000, an enormously high burden of disease and mortality. The perhaps most shocking aspect of this is that by transitioning to clean renewable energy, we can offer reliable energy to people living in low-income settings without access to the grid of electricity. So transitioning to clean renewable energies can actually offer a solution to the global problem of energy poverty. And that it becomes even more important given we have about 1 billion people that today are served by healthcare facilities that lack reliable access to electricity. We've been in discussion with the WHO about that, and they were telling us about their efforts in terms of electrifying healthcare settings and healthcare buildings in low-middle income countries, particularly in sub-Saharan Africa, where often women have to deliver in the dark because there's no electricity in hospitals. Another aspect of the transition that could offer enormous health benefit has to do with our diets and our food systems. Food systems contribute to about 1/3 of all global greenhouse gas emissions. And when we look at the agricultural sector, about 60% of all agricultural sector emissions come from the production of red meat and dairy, mostly because of the contributions of methane from ruminants and from the land use change of cattle rearing. From 2000 to 2020, we're seeing an increase in agricultural emissions, mostly driven by an increased volume of the global population and an increased consumption of meat in diets. The flip side of this is that an excessive consumption of red meat and dairy is contributing to about 12.2 million deaths that could be avoided through transitioning to balanced low-carbon diets, so-called the planetary diet. So we have 12.2 million deaths to avoid, and then about 1/3 of all global greenhouse gas emissions to reduce by transitioning to healthy diets globally. And if we look now at what happens across different Human Development Index country groups, it is now the very high Human Development Index countries that have the highest burden of death attributable to low consumption of nutritious plant-based foods and to excessive consumption of red meat, processed meat, and dairy. So here's another area where we could save millions of lives each year through health-centered transition to low-carbon systems. And finally, as you will know, the health sector. The health sector is a very big emitter, very big contributor to greenhouse gas emissions. It contributes, we estimate, to 4.6% of all global greenhouse gas emissions. And this, well, it might sound little. Taken in perspective, the aviation sector contributes to about 2.5% of all greenhouse gas emissions, and that has led to enormous efforts globally to decarbonize the aviation sector. If it were a country, it would be the 5th highest emitter globally. So it is substantial, and it has an enormous control over 10% of all global GDP, which gives it power over an enormous proportion of greenhouse gas emissions that trickle down the whole economic system. Importantly, these emissions and the consumption of electricity from our health settings contributes to 4 million disability-adjusted life years annually. This enormously high burden of disease, the contributions to greenhouse gas emissions could be avoided by transitioning to sustainable low-carbon health systems, which is essential to provide care without doing harm, and which will become inevitable as the world transitions to a net zero future. So there's a lot that we need to be doing as healthcare professionals, as healthcare providers, to enable this transition to healthy low-carbon health systems. Now, why haven't we transitioned so much? I always like to show these slides because I think it brings it into perspective. There's been a lot of talk about transitioning away from fossil fuels in the last COP negotiations. And of course, fossil fuels are the biggest single contributor to greenhouse gas emissions. Tackling our energy grid, our energy sector emissions would be the single biggest thing we could do in terms of tackling climate change. Fossil fuel companies have been promising a net zero future for years and years. But when we look at what they're actually doing, when we analyze their investments and their financial commitments, we see that the 20 largest oil and gas companies are increasing their investments towards fossil fuel production, even in the last year. Their contributions in excess of the Paris Agreement goals has increased by 61% from 2022 to 2023. And the reason why I'm showing you this is because if we understand that climate change is the biggest determinant of health globally, then this is the biggest contributor to our ill health globally. There's a lot that we need to do in terms of bringing accountability to the energy sector, and particularly the fossil fuel companies that contribute to it. And there's a lot that our governments need to be doing in terms of providing that accountability. Oil and gas companies are being promoted in their activities by governments worldwide. When we looked at the 87 countries that contribute to about 95% of all global greenhouse gas emissions, 68 of them still had net negative carbon prices in 2020. This means that looking at the overall health subsidies, the overall health taxes, they're still overall allocating public taxpayers' monies to promote the production and consumption of fossil fuels that jeopardize our health. And what's even worse is that when we look at what this means in total terms, in 2020, the year of the COVID-19 pandemic, where health systems were on their knees, these governments allocated collectively $305 billion towards subsidizing fossil fuels, net subsidies to fossil fuels. 30% of the countries allocated more than 10% of their total health budgets to fossil fuels. And what is even more shocking is that when we look at what that means in terms of climate action, the highest income countries have still not managed to deliver the 100 billion promised in 2009 to support low middle income countries in tackling climate change and facing climate hazards. So we're really prioritizing the oil and gas companies over our health, over our survival in many cases. The good news is that there's a lot that we could do to revert the situation, and that could still enable a thriving future. To start with, there has been a lot of progress over the past year. I hope that you've all seen what happened in the last climate negotiations at COP28. COP28 that happened at the UAE in Dubai last year had the first ever health dedicated thematic day. This brought the first climate and health ministerial with over 50 ministers of health coming for the first time to a climate negotiation, talking about why climate action is so important for health, and health needs to be prioritized and mainstreamed through climate action. 143 countries signed to the COP28 Climate and Health Declaration, stating the need to deliver climate-focused health-focused climate action, and to deliver low-carbon, sustainable health systems that are resilient and adapted to a climate change future. We've also seen the commitment of $1 billion for climate and health finance, the global goal on adaptation that says the global collective goal for climate adaptation specified a specific target for health within the adaptation efforts, and the global stocktake, the document that monitors progress towards the Paris Agreement goals, recognize the right to health and a healthy environment as a key goal of the Paris Agreement actions. And soon we will see also very meaningful progress within the health sector itself. A new WHO resolution is now being discussed, putting climate change and health as a center point in terms of how health systems prepare for the future. And the new general program of work, the GPW14, will also feature climate change, climate resilience, and healthy low-carbon societies as a key priority for the next 5 years of our global health efforts. There's a critical role for health professionals to be playing in this. The health sector will be, as climate hazards increase, the first line of defense to protect people and their health from the climate change related hazards, and is crucial for climate change adaptation. Health professionals can also help increase knowledge and awareness of the health risks of climate change, the health opportunities of climate action, and contribute to policymaking that prioritizes health and the health co-benefits of both mitigation and adaptation. Public health policies can also significantly contribute to decarbonization. We could be delivering dietary policies, air quality control measures, health policies themselves that contribute to health system decarbonization, delivering healthier, more resilient societies. We have direct control over 4.6% of all global greenhouse gas emissions and 10% of GDP, which is an enormous amount. And we can also put health at the center of our climate policymaking. For this, we need health professionals to take the lead, to stand up to the challenge, and to be involved within the climate discussion globally. And with that, I invite you to visit lancetcountdown.org. You can find the 50 indicators that we have in the report, explore them in much more detail, as well as download the report from there. And I'm happy to take any questions.
Wonderful. Thank you so much for that very informative presentation. I think it gives us all a lot to think about. This is the time for the question and answer session. So please feel free to submit your questions in the chat. I do have a couple questions, but we have our first question from the audience from Dr. Herman. Why does the US healthcare industry produce so much GHGs compared to other OECD countries?
There's two things. The US has an enormously high level of expenditure on health. There's a lot of overuse of health within the US. If you compare the US health system spend and the US health system service provision with that of other countries, even countries that perform better in terms of health outcomes, the US spends an enormous amount, mainly because of how the health sector has evolved as a market, as a private market. If we compare it to many European countries, it is orders of magnitude more what the US emits than what the public health systems in other countries emit. There's been a lot of work happening in the US in terms of reducing the overspend and the overconsumption within healthcare. And there are good efforts, some led by Yale, by Dr. Jody Sherman, in terms of building awareness of reducing waste, reducing overconsumption in health settings. But it has to do mainly with overconsumption and inefficient consumption of resources.
Great. But Jeannie, thanks for that. If folks would prefer to ask their questions themselves, they can also please raise your hand and we can unmute you. Are you seeing a shift in funding priorities from some of the biggest funders? Obviously, it costs a lot of money to implement mitigation and adaptation strategies. And what are you seeing from the funding side of things?
Look, the NIH has done a huge shift in terms of starting to fund much more work on climate change and health, both in the US, but more especially internationally in partnership with low-middle income countries. The NIH has been driving an enormous amount. Back in England, the Wellcome Trust has also put climate change and health as a core priority. And we're seeing funders all around the world, particularly funders that have traditionally focused on purely health and health delivery, are now shifting to climate change and health as a core priority. So we are expecting to see much more happening soon. The $1 billion that were committed last COP were, I think, a starting point. But there's a problem of awareness. Most funders are still unaware of the extent to which climate change is undermining their efforts towards health improvement in other aspects, even as they design strategies for kind of traditional programs of healthcare delivery in low-middle income settings. Like we're seeing organizations focusing on malaria, on tuberculosis, on any sort of basic healthcare delivery. They are already seeing their activities being undermined by climate change through disruption of supply chains, through disruption of hospital infrastructure. So they're now starting to realize that if we don't adapt to climate change, they will not be able to continue with their other programs of work, even if they don't want to look directly into climate change and health. So whether by active choice or by need, they are shifting a lot more towards providing finance for climate and health. Much of it, though, is still very focused on healthcare resilience, rather than on promoting the health co-benefits of climate action, where we can play a very major role.
Do you have any recommendations for resources, standards, or goals specific to reducing healthcare system global greenhouse gas emissions?
Sorry, can you repeat that?
Do you have any recommendations for resources, standards, goals specific to reducing healthcare systems GHGs?
Yeah. Look, we're working on a new commission from the Lancet, where we will be looking precisely at that, at what are the standards, what is the best practice in terms of reducing greenhouse gas emissions from healthcare settings. But in a nutshell, there's a lot that can be done very immediately, very kind of low-hanging fruits. Anesthetics are one of the key areas of action. Gaseous anesthetics are very powerful greenhouse gas emitters, particularly nitrous gases and fluorinated gases. So whenever it's safe for the patient, whenever feasible, transitioning towards injectable anesthetics can save a lot of greenhouse gas emissions. The same with inhalers, with the asthma inhalers. Shifting to power-based inhalers rather than propeller-based inhalers can also contribute a lot towards the scope 3 emissions from the health system. But beyond that, anything that reduces and optimizes the use of resources from the health settings will already contribute to reducing greenhouse gas emissions, whether it's from reducing wasteful consumption of energy by better managing lighting systems, heating systems, or whether it is by reducing the use of disposables whenever safe and using more reusables. All of those activities that optimize the resources, that reduce waste and reduce overconsumption will have an enormous impact on greenhouse gas emissions. And I would suggest that you look into the NHS in England. That was the first health system to commit to reaching net zero by 2045 across all of its scopes of emissions, even the emissions that they contribute to through supply chain and through induced travel. And they have set a path and a route towards decarbonizing their activities, which can be an enormously good lesson to be learned also from other healthcare providers.
Of which you played a leading role, I understand.
Yeah, well, in the analysis of their footprint and the modeling of how they can deliver it, but they have done quite a lot of work. Actually, they did it with local practices and with engaging with practitioners, GPs, and it's the health system in the UK is kind of atomized. They have a lot of trusts that have quite a lot of independence. So they've done it alongside the trust in trying to understand what can feasibly be done in a health setting, because what we can do from the theory sometimes does not apply, it's not feasible, it's not practicable on the ground. And they have done a big job of engaging with practitioners to see what is feasible and what is more easily doable. So it's quite an interesting example as a case.
We have another question from Dr. Hirschau. He's the head of our Division of Epidemiology. As you point out, $205 million as you point out, $205 million on adaptation projects. How can we shift from work that demonstrates the deleterious effects of climate change to research that provides data on what adaptation interventions work best and are the most cost-effective ways combating climate change, particularly in low HDI settings?
Yeah, look, that's a crucial aspect. We still have very little on-the-ground evidence of interventions that work best. What is the best practice? Part of that is, there's two problems. One is that we're doing a lot of interventions and we're not doing the evaluation that is necessary after the intervention. So interventions are rolled out, but then we don't evaluate them. So we have no idea whether they've worked or not. We do a lot of policy recommendations based on our data. And we work with countries all around the world in terms of trying to help them devise policies to address climate change. And what we often find is that there's a lot of policies that have been implemented, but no one has any idea of how effective they've been. So the first thing is, both from the government, but also from the research sector, from the academic sector, starting to look at those implemented policies and helping governments, helping policymakers and policy settings in being able to assess, to evaluate the effectiveness of those policies, something that is not always easily done because of the political tensions that come to play when you implement a policy. And then the other thing is the scarcity of data. Most countries don't report their health data. We have very little access to effective health data. Most of what I showed you, as I said, when I showed you the heat-related mortality, that is model data. But in order to see what's happening in terms of adaptation, whether the implementation of adaptation measures is or not saving lives, we need to know how many lives have been lost before and after the adaptation measure, and that requires bottom-up data collection. And we're still seeing a big resistance and reluctance in terms of data sharing that we are working with the WHO to try to address, and trying to help countries through the provision of tools and know-how and knowledge transfer in terms of being able to collect and report that data. So we have both the problem of not looking at what's happening and then not being able to look at it because we don't have the data bottom up.
I imagine increasingly too, it'll be hard to have, in terms of health, a counterfactual, because you'll have no person that's unexposed.
Yeah, that's true. So one of the things that we do in terms of that kind of counterfactual, in terms of doing what we call climate attribution, that is understanding whether an impact has had to do with climate change or is related to other factors, there is a whole body of work that is emerging now in terms of how to attribute health impacts to anthropogenic climate change. And that relies mostly on climate models that have that counterfactual of what the climate would have looked like. So you can model that counterfactual. But to your point, what is very difficult to do if you don't have bottom-up data collection is understanding the attribution to the policy implementation. How it's a certain policy is reducing the vulnerabilities, how it's reducing the mortality, and how it's shifting effectively that exposure response function. That is what we care about, reducing the impact of environmental exposures, because you have more resilient health systems, more resilient infrastructures. And that's what requires bottom-up data collection.
Okay, so we have a couple more questions here. Whoa, we have a number of questions. Okay, so this person's saying, first for clarification, the healthcare industry emits more greenhouse gases than the aviation sector. Can you please clarify that? And then what is the aviation industry doing in regards to emissions, greenhouse gas emissions?
Yeah, well, the whole global health sector emits more, almost twice more, than the total global aviation sector, which is quite shocking when you think about it. It will have to, the emissions from the health sector will probably increase still a bit more, particularly in low middle income settings, as we increase access to healthcare and universal health coverage. So healthcare is an essential service. The aviation sector is very difficult to decarbonize, not so much so the health sector, which is the good news. We can do a lot more in terms of decarbonizing the health sector so far than we could do so far in terms of the aviation sector. But for aviation, one of the main things where the efforts are being focused is in terms of using green sources of energy. So how do you replace fossil fuels to carbon neutral fuel sources like green hydrogen or other types of fuels? I'm not an expert in aviation, but I know it's very difficult. Green hydrogen is still enormously expensive. The technology exists, but it's still very unfeasible to be done at scale.
Thank you. Another person saying, hello, I'm from Buenos Aires. Just wanted to thank you for your presentation. About what you say of droughts that affected the agriculture sector in Argentina. Also, this last summer, we had increasing rains and flooding in the metropolitan area of Buenos Aires. Considering that this is estimated to increase in future years, I don't think we're having enough adaptation strategies in the country. So I guess more of a comment.
Yeah. Yeah.
What do you believe public health leaders' roles could or should be related to maintaining a healthy, stable food supply through fires, droughts, hurricanes, heat waves, etc.?
Well, food supply, flood risks, any climate hazard requires first an identification of the hazard and then a plan to build resilience. Same as what has just been mentioned with Buenos Aires. In most countries, we're not really paying attention to climate change as we should. So by and large, what we see is that we could adapt very effectively to a 1.1 degree world. That is what we're currently seeing. We're currently at 1.1, 1.2 degrees of heating. We could have adapted very effectively. There's no reason why we would be facing the impacts of climate change at 1.1, 1.2 degrees of heating. We, in theory, should be able to adapt to most of the hazards of a 1.5 degree world. But the reality is that we're not being very effective in terms of adaptation. We're not being able to identify the hazards effectively. And when we do, we don't have the governance and the political levers to implement the adaptation measures needed. And more often than not, it has to do with lack of policy, with lack of governance, and with lack of political will in terms of developing these adaptation measures. It's cost effective, it saves lives, it saves money. We know that the cost of adaptation is much less than the cost of climate change if we don't adapt. We know that it's cost effective, but there's just not enough political will to make the capital investments for effective adaptation. And that is the problem that we're facing throughout.
All right, it sounds as if one of the limitations, this is another comment, it's a comment. It sounds as if one of the limitations to reducing greenhouse gas emissions on US healthcare systems is our focus on tertiary treatment rather than primary preventive care.
And I would say not only in the US, I think that's a global problem. It's very interesting in terms of primary care, there's a lot that can be done through climate action as well. So reducing exposure to air pollution by reducing fossil fuel burning and burning of dirty fuels can help build more resilient, healthier societies that reduce the demand on healthcare. So that is one of the things. And definitely transitioning to primary preventive medicine is always the best choice. It's generally also less carbon intensive. One thing that is interesting, though, is that when we've had these discussions of how to shift what we call the pathways of care, how do you treat a patient, or how do you prevent the patient from having to go through the most carbon-intensive routes of care? Primary prevention is always up there, but increasing prevention and building healthier societies does not necessarily mean that you will reduce the demands and the carbon footprint of healthcare. It will mean that you will provide more healthcare to healthier populations. An example that I love to give, because I find it so outrageous, is the new fashion of MRIs in the US. I've seen top models, celebrities, all going and getting MRIs just in case. So that could be very effective preventative measure, maybe. It's very carbon intensive, it's very wasteful, it's not the best use of public resources by no means. So the way that we use prevention is very important, and particularly identifying which are the lowest carbon paths of care and the paths that also improve patients' well-being and reduce the demand on the health system because you have healthier patients.
Good. We have one question from Keith Partica. He works with the Global Health Program here at the School of Public Health. Jeannie, if you can let Keith speak, please.
Hi, can you hear me?
Yeah.
Hi, Dr. Romanello. Thank you for a terrific presentation, really eye-opening presentation as well. I was shocked when you reported how much money the oil and gas companies received in 2020, just a shockingly large amount of number. Considering they have a large amount of money, strong lobbying groups, work in countries where there might not be strong regulations on those industries, what do you have some ideas and ways they could be held more accountable?
Let's see. I think that's the kind of the holy grail. There has been a lot of progress in terms of removing the social license of oil and gas industries to operate. They have the biggest marketing tool in the world, the biggest marketing machinery in the world. And they operate under what we call the polluter's paradox. That is a paradox whereby the companies that most pollute are the ones that have the most interest in lobbying governments to reduce pollution control measures. So they're the ones that invest the most in lobbying against pollution control measures. And that's exactly what the oil and gas sector does. Trying to tilt that balance is very, very difficult. But we believe, and we have scientific studies from the social science part of our work that suggests this is so, that when you put health at the center of the conversation, you start already to reduce the social license from oil and gas sectors to operate. That's why putting health at the center of the climate conversation is so powerful, even as a policy tool. If we make it clear that when we look at Chevron, at Shell, at BP, or even at Saudi Aramco, or any of the big oil and gas giants, what they're doing is jeopardizing the health of our loved ones, of our children, then the discussion changes. And the accountability has to go from health impacts of climate change, greenhouse gas emissions, and emitters. And that is the route that we're trying to do. There's been some progress in terms of climate litigation, trying to hold oil and gas companies accountable as well. And there's a lot more interest that we've seen in the past 2 years, I would say, in terms of using the health impacts of climate change to keep oil and gas companies accountable through litigation and through legal action. And we're hoping that through better data that allows us to attribute health impacts of climate change, to greenhouse gas emissions, to emitters, we will be able to make that chain a lot clearer and hopefully keep them accountable. But as I said, they have most governments in their hands, and that's the problem that we're facing. Not only in low-income countries, I would say, perhaps not mainly in low-income countries in any case.
Okay, so let's look. Looks like we have 2 more questions coming in. Are there any countries, and we're nearing the end, so this is a good question. Are there any countries that can serve as models of doing things right regarding climate change?
Well, it's difficult to call out a country that's doing things right. There's examples of things that have been done right. I wouldn't say that any country is the paradigm of climate action, but there are very good examples. I'm very familiar with examples in Europe in general, because that's where I work most of the time. The European Union is doing a lot of progress in terms of reducing its emissions. It has done so very effectively, arguably mostly because it has tackled its coal emissions, which is a very low-hanging fruit. There's been really great action in terms of reducing air pollution through mitigation activities in China even, which is a country that is generally looked as a big pollutant, not so per capita. And they are doing very good progress in terms of transitioning to renewables. And there's excellent examples from low-middle-income country settings in terms of nature-based solutions, in terms of increasing access to urban green spaces. Colombia is doing magnificent work in that sense, in re-urbanization and people-centered urbanization. Bogota is a great case study for that. So there are cases to be learned from around the world. Every country has a different constraints, different settings, and different conditions. So it has to be very, very tailored to the local level.
Great. Okay, we have one more question coming in. Just a comment. There's quite a bit of work being done in the Caribbean to address this.
Yeah, absolutely. And the Caribbean, it's small island developing states in general are doing a lot, particularly in mitigation, but also in international legal action against polluters. They're at the front line of climate change. They are doing a lot in terms also of relocation as an adaptation measure. How do you safely relocate people to promote their health, their well-being, and not as an adverse impact? And they're doing a lot in terms of understanding much better what the health impacts of climate change are, because they're so ridiculously vulnerable. But again, out of need. And the problem is that it shouldn't be out of desperate need. This should be a proactive effort globally, and we're not giving them enough support, really.
All right. Are there any other questions from the audience? Thank you. See if there are any raised hands. Doesn't look like it. All right. Well, Dr. Romanello, thank you so much for your spectacular presentation, joining us, sharing your time with us for this UIC Global Health Colloquium, also a part of National Public Health Week. So really, we just can't thank you enough. We really appreciate it, and we look forward to future opportunities to collaborate with you.
Thank you very much.
All right. Take care. Thank you. Okay.
Bye.
Bye-bye.